All righty, let's get started. We are down to it. Today is Wednesday, October 13th. This is our last lecture for the third section of this class. So we are rapidly working our way through the semester. We have to finish up our discussion of joints and then finish up our group presentations on the appendicular skeleton. I don't anticipate that will take us the whole class time. We'll see how things go with that. And if there is time at the end, then as always, I'm happy to do a question and answer review for the exam to help us to prepare. Again, you do still have one assignment left. If you've turned it in already, awesome. If you haven't, please make sure you turn it on time. Again, I don't like having assignments that are due when we're not in class, because coming to class is a good reminder. But because we haven't finished all the bones and bone features, I did want to give people an opportunity to help to understand the information, since this is something that is graded for correctness. So please turn it in on time. It's worth 30 points. You don't want to lose half of that for being late. So after, today, after we're done with class and we've done the bone and bone features, that's a perfect opportunity to go out, finish it, and then turn it in so that you don't forget. All leading up till Monday when we have our next lab and lecture exam. All right, and that's it. Like I said, the schedule gets simple as we reach the end. All right. Questions on any of that? All righty, then, oops, I gotta get to the right place. All right, we left off last class and we were talking about the functional and structural classifications of our joints. There are 3 functional classifications, and again, the functional classifications are based on the amount of movement that they allow. And 4 structural classifications. Structural classifications are primarily the type of connective tissue that holds the bones together, but because of this 4th type, we also can throw in the whether or not there is a cavity present as part of that definition. And remember, also on top of this, we identified that that some of these are fibrous, for instance, has 3 specific types. Our cartilaginous has 2 specific types. And as we left off talking about in the last class, there are 6 specific types of synovial joints. And that's what we need to talk about. We need to talk about these synovial joints. We know that all synovial joints are diarthritic, and all diarthritic joints are synovial. Remember, that means they give a free range of motion, but remember, it also can be restricted in the ranges of motions that they allow. And what range of motions they allow is going to be determined by their shape. So we need to talk about the shapes of those 6 specific types, and that will help us to understand the types of movements that they allow. Before we can do that, we need to talk a little bit more about the synovial joint itself. Here is the most basic synovial joint. Again, we just have 2 ends of bones coming together, and there are 4 major characteristics that all synovial joints must have. And that's what we see here. Again, there are characteristics, 4 characteristics that all synovial joints must have. And that's what we actually see here in this picture. Notice the first is something that we have already talked about, and I know you guys mentioned in the last class as well. Notice at the end of the bones, we have that hyaline cartilage. If this is going to be a free moving joint, we don't want these bones damaging each other. And since we don't want them damaging each other, we need to provide some protection on the ends of the bone. And so one of the important characteristics that all synovial joints must have is what we call the articular cartilage, right? Again, that's basically a location name, because what kind of tissue is that articular cartilage?
Hyaline.
Yeah.
Dense irregular.
Now it's a hyaline cartilage. It's that hyaline cartilage at the end. And again, this is hyaline cartilage whose specific job is to provide that cut cushion, reduce that friction. And so we give it that name of articular cartilage based on that. This can probably be a little bigger. So that's the first characteristic. The second characteristic, as we mentioned, this is the only joint that has a joint cavity. Oops, that's not how you spell has. Has a joint cavity, right? So that is another important characteristic. And obviously, to make this joint cavity, it has to have a joint membrane. Now, if we look closely at this joint membrane, there are actually two, or let's say it this way, a joint capsule. There is a capsule that surrounds the joint, and this joint capsule has two parts to it. The first component, as you see on the outer surface of this, is basically a fibrous connective tissue structure that is going to give some integrity, is going to give some strength to this. And this is known as the fibrous capsule. This fibrous capsule, like I said, is a dense irregular connective tissue, and its job is to hold the bones together, give some strength, give some integrity. However, notice also on the inside of this is a little green line. And that little green line that is lining the inside of that joint capsule is that synovial membrane we talked about in the last section. Like all membranes, it's made up of an epithelial tissue that sits on top of a connective tissue. But if you remember, our synovial membrane was a little bit unique. Did it have a fully intact, fully complete epithelial tissue? Does anybody remember? Well, I'm asking the question, so what should the obvious answer be?
No.
No, exactly. If you remember, it was just small clusters of cells. We called it, if you remember, a scant layer, which basically is a fancy way of saying it's incomplete. It's an incomplete layer of epithelial cells. And remember, even the connective tissue was special. It is a real connective tissue because practically everything's a real connective tissue. But remember, we also said it had a more extensive matrix, more fibers in it, so that it would be more protective and more durable for the movement that it was allowed. So we have this capsule, this joint capsule that forms the joint cavity. And lastly, what is that joint cavity filled with? What is it that the synovial membrane makes?
Synovial fluid.
Yeah, exactly. And unlike serous fluid, where we just want a thin layer of it, we want to actually fill the cavity with synovial fluid. Now, let's be careful about that. Do we make a little bit of synovial fluid and fill it with synovial fluid, and you did that as a baby, and that same synovial fluid is in there right now that you had in there when you were a baby?
No.
No. So what is the function of this synovial fluid?
To lubricate?
Absolutely. One of the important functions of this is to, again, provide that cushion and lubrication for the joint. However, if we just made synovial fluid at the beginning of our lives and stuck it in there, or if we put adipose in there, adipose is slippery, adipose provides cushion, but that's not what we do. We constantly make synovial fluid, fill the space with synovial fluid, and then reabsorb it. So we are constantly circulating our synovial fluid. So if the goal was just cushion and lubrication, there are other ways we could do that more efficiently. So why is it that we're constantly making and recycling? That synovial fluid must be doing something else. What do you think?
Is it heat regulation or?
That's a great one. I will say that it isn't about heat regulation, although changes in temperature do change the amount of synovial fluid that it is producing. So there definitely is a relationship between temperature and synovial fluid production. If you look at the end of those bones, notice that they have that hyaline cartilage on it. And what do we know about hyaline cartilage again?
It's smooth and glossy.
Oh yeah, okay, it's smooth and glossy. What else do we know about hyaline cartilage, or really all cartilages for that matter?
Fibrous.
True, they do have a lot of fibers in them. What's the big difference between cartilage and bone? There you go, vascularization, exactly. Remember, cartilage is avascular. It doesn't have a direct blood supply. So by having the synovial fluid bathe over the surface, the other major function is that it helps to maintain the cartilage, so that it's providing oxygen and nutrients. It's removing the wastes. So it helps to maintain the integrity of the cartilage, maintain the health and integrity of the cartilage. All right, so every single synovial joint in your body, right? What's probably your biggest synovial joint?
The knee.
Knee is pretty big. The knee is a big one. I'm not sure I would say it's the biggest, though. It might be second, maybe third. What do you think the biggest one is? Maybe a little proximal to that? Yeah, hip. I think hip might be the biggest joint. After all, the femur is the biggest bone. So yeah, either the knee or the hip are probably the biggest. So those have this four components. Anyone guess what the smallest synovial joints are? We've actually talked about the bones. Thumb's a good guess. No, we get way smaller than that. You remember those tiny little auditory ossicles we found in the ear, where all three of them fit on the tip of your finger? The malleus, the incus, and the stapes? Those three tiny bones actually form synovial joints. So from those tiny bones inside your ear all the way up to your hip and your knee, every single synovial joint in your body has these four characteristics. So again, it's the articular cartilage on the bones, that articular capsule that has the two components, the fibrous and the synovial membrane, that joint cavity filled with synovial fluid. Every single joint has that. Now, we have this picture here of a very simple synovial joint. Is that what the hip or the knee or the shoulder looks like? This picture right here? No. So while these are the four things that, again, I guess I want this back, if for no other reason than to emphasize what we said here. These are the four characteristics that all synovial joints must have. We can also say that most, of course, most means not all, synovial joints have one or more accessory structure. These things are structures that are not required for synovial joints, but many of our synovial joints have one or more of them. So let's talk about some of these accessory structures. That I can get rid of. This I can get rid of. So we can keep this. Here, for instance, is an example of our shoulder joint. And in this shoulder joint, one of the things that you can see is how, for instance, there is a tendon. What is a tendon again? Come on, guys. I know it's early in the morning, but this is a cumulative class. What is a tendon? Yeah, a tendon is a dense regular connective tissue that attaches muscles to bone. Absolutely. Notice here we have our bicep brachia, and it has a tendon that actually comes and attaches to the scapula, the roughened bump above the glenoid cavity. Remember, that's the supraglenoid tubercle that we see there. So we have that there. So there can be tendons or ligaments. Ligaments, of course, attach bone to bone. There isn't an example of this one here, but we will see others. And these tendons and ligaments can add additional structure and additional integrity to our bones, to our joints. We can also form extensions of the synovial capsule. That articular capsule, and let's do a simple drawing of this. So here's one bone, here's the second bone. Again, as we've talked about, there is going to be this articular capsule that is going to surround it. But one of the things that can happen is there can be an extension of this synovial capsule. And this extension of the synovial capsule is known as a bursa, or bursae being the plural. As an extension of this synovial capsule, it is going to contain synovial fluid inside of it. And so basically it forms essentially a fluid-filled pillow in the joint. And that's actually what we see right here. Right here in this joint. Let's use a bigger arrow. We can see an extension of the joint capsule forming a structure called the subacromial bursa, which should tell you everything about it. Sub means below, acromial refers to the acromial process. And so notice here in the shoulder, every time I elevate my arm laterally, I don't want the head or the neck of the humerus banging against the acromion of the scapula. So to help to cushion it and protect it and help to hold and stabilize the shoulder in place, there is this bursa sac. Now, as we mentioned way back in the second section of the class with this synovial membrane that's on the inner surface, if this synovial membrane gets irritated, it can overproduce fluid, causing the joint to swell and become stiff and become irritated. We talked about how you could go in there and draw the fluid out with a needle, but you're still damaging it. Well, the same thing can happen with a bursa. If the synovial membrane of the bursa becomes irritated or damaged, you can get an increase in synovial fluid that will push and cause swelling of the bursa. And of course, what do we call that condition? Inflammation of the bursa.
Bursitis?
Yeah, bursitis. There you go. Exactly. Right, bursitis, right? Haven't you heard grandma complaining about her bursitis in her knee or something like that in her shoulder? Notice in this case, bursitis of the subacromial bursa could actually cause a depression of the humerus in the shoulder, limiting your range of motion. So these bursas help to provide cushions, but like the joint themselves, they can become irritated. They can become damaged and become inflamed, causing a bursitis. Exactly. Now, the other thing that can happen with these bursas is that they can elongate and form a tube-like structure that the tendons pass through. This elongated tube-like bursa is called a tendon sheath. Again, we see one here with our shoulder, but the one we talked about in the last class is much more common. There is a tendon sheath right here in the wrist region that wraps around the tendons, blood vessels, and nerves going to the hand. And remember, as we talked about, with a lot of repetitive actions, those tendons will inflame inside that tendon sheath, and that constricts the blood flow, and that constricts the nerves. And so you get a weakness, you get a tingling, your fingers get cold and painful. And what did we call that condition again?
Carpal tunnel.
Yeah, carpal tunnel syndrome. Absolutely. It's carpal tunnel syndrome. In extreme cases, again, it's not the first thing they will go to, but if someone has chronic carpal tunnel that isn't able to be resolved in other ways, one of the things they may do is go and actually cut that tendon sheath. And when they cut that tendon sheath, that releases that tension, and it can cause a dramatic decrease in symptoms. Now, there can be other complications with cutting a tendon sheath, so it's not the most common way that it's dealt with, but it is something that is occasionally done.
Isn't it the same for trigger finger? They kind of go in and
I'm not familiar with that condition, but if it's an inflamed tendon sheath, then yeah, that would be another extreme way that they could do it. I just don't know. I'm not familiar with that condition. All righty. Let's take a look at a different elaborate joint. This one is the knee. Notice there's a lot of elaborate joints in the body. This is one where you are going to actually be responsible for the specialized structures of the knee. We will save that till the end of class today because I want our groups to present the bones and bone features first before we put them together to make the knee. But we can look at it now to identify some of the other structures that we're going to be responsible for. The first is a big, huge chunk of fibrocartilage. Notice we know articular cartilage is hyaline cartilage, but we can also have a big chunk of fibrocartilage in the joint. This can provide extra stability and extra cushion. And that chunk of fibrocartilage that we find in the knee is known as the meniscus. Meniscus singular, menisci plural, and your knee actually has two of them, and they're actually, one's kind of circular and the other C shape, and they form this cushion to help, again, as we know, fibrocartilage helps in compression, helps to resist and act as a shock absorber, and so it stabilizes the knee and provides that shock absorption in a very weight-bearing joint that we have there. And fibrocartilage isn't the only thing that can provide cushions within a joint. Some joints will have a fat pad. Guess what a fat pad is made up of?
adipose.
Yeah, adipose tissue, absolutely. Notice in this case, in the knee, we have this peripheral bone to the knee, the patella, that as you flex and extend your knee, that patella could potentially bang against the anterior part of the tibia. So to protect that, to loosely stabilize it in place, we have a chunk of fat, which is why you can reach down and wiggle your kneecap. You can go reach down and wiggle your kneecap, assuming your leg's not fully flexed. If your knee's flexed, then you can't wiggle it. But if your leg's extended, you can wiggle that because it's loosely held in place by tendons and by that fat pad. All right. So like I said, none of these structures are required for a synovial joint. The only things that are required are those four things that we already talked about, but most joints in the body have one or more of these. And so, well, like I said, and then as I mentioned, we will talk about the anatomy of the knee, identifying all of the structures you're responsible for. But I think it'll be more meaningful to do it after our groups have presented their bones and bone figures, bone and bone features, so we can make more sense of it then. All right, questions on the basic anatomy of a synovial joint? All right, excellent. Then what we are going to talk about next are the 6 specific types of synovial joints. Here we see the illustration, and as we mentioned, these 6 specific types are going to be identified based on the shape of the articulating surfaces. However, the other important thing to remember is that the shape of the articular surfaces determine the movements that they allow. So if we're going to talk about the shapes of these, we also have to talk about movement a little bit, and that's something we haven't talked about yet. So the easiest way to do this, and usually I'm sitting in the classroom and I have the big desk in front of me and I have my yardstick in front of me, and so it's a little easier to see and represent that, but I can cheat and we can do the same thing here with, like we have here, a piece of paper and a pen sitting at the center of it. And basically the plane of paper and the pen are the two surfaces that we're talking about in their relationship to each other. And notice right now their relationship is basically perpendicular. Now notice one way I can move these in relation to each other is I could take the pen and I can slide it back and forth along the surface of the paper, forward and back, left and right in a big circle. Notice as I'm moving this back and forth though, the angle between the paper and the pen don't change, right? So they stay perpendicular to each other. This type of movement, and again, you could do this with your hands as well. Notice your hands can slide back and forth across the surface of each other, but the angle between them doesn't change. That type of action, that type of movement is what we call a gliding motion. And it is a non-axial motion. There's no change in the axis. There's no change in the angle. All right, so that is a gliding motion. However, I can change the angle. If instead I anchor the tip of the pen, then I am able to move it to the left or move it to the right, and I can change the angle. I can go from 90 degrees to 45 degrees to 110 degrees. I have that ability to move it back and forth. And that would be an axial motion. Again, notice we have joints that do that. For instance, as we mentioned here, the joint between my phalanges, and now we can be more specific, the proximal phalanx and the middle phalanx. I can change the angle between them. But remember, as we also talked about, I can't make the finger go to the side. So notice in this case, this is an axial motion, but only on one axis. So that would be uniaxial. However, the joint between my metacarpal and the proximal phalanx is a different type of joint. Not only can it go forward and back, but it can go left and right. Notice it can move on two axes. And if it can move on two axes, guess what we call that?
Biaxial.
Biaxial, absolutely, right? And then my shoulder can go forward and back, can go up and down, and can go angles in between. So if you can go more than two axes of motion, there you go, Jackie, we call that multi-axial. So notice we have these different types of motions, these angular motions now, that can be either uniaxial, biaxial, or multi-axial. Now, and I'll use my finger because it's a good example. If you have at least biaxial motion, then what you're able to do is combine those together. Notice if I put my finger up and then right and then down and then left, and I continue to do that. Essentially what happens is the tip of my finger draws a circle while the base of my finger stays the same. That type of motion is what we call a circumduction. So anything that is bi or multi-axial are capable of circumduction. But there's one type of movement as well that we haven't talked about. I can leave my pen here, and I guess I'll get a little bit closer so we can see this, the pen on the paper, not change the axis, but also not move it. Instead, I can rotate it on along its vertical axis. Notice I'm not rotating it this way. I'm rotating it just along the vertical axis. And guess what we call this when I rotate it on the vertical axis?
Rotation.
Yeah, we call it a rotation, exactly. So these are two additional types of actions we can make. We have that ability to do circumduction. We also have that ability to do rotation. So when we talk about the joints, every single specific type of synovial joint will allow one of these types of actions or more. All right. Questions on that? All right, let's work our way through the specific types of synovial joints then. So again, whoops. We name them based on their articular surfaces. And like we talked about, their articular surfaces are going to determine the movements they allow. The first of our specific types of synovial joints are what are known as planar joints. Notice with planar joints, you have two flat surfaces that sit against each other. And they allow that non-axial gliding to take place. Right? Notice to do this, we need flat surfaces. So if you look at the examples that we have here, the examples of this are in the short bones, like in the carpals and like in the tarsals. Now, we need to be careful because when we think of the wrist, we think of this, right? When we think of the wrist, we think of this as our wrist. However, as we now know, that joint is actually caused by the radius in the ulna and the scaphoid in the lunate. If I actually want to see the intercarpal joints, what I have to do is I have to stabilize the wrist. And notice with my wrist stabilized, I'm still able to move my hand a little bit back and forth. And the reason for that is those carpal bones are slightly gliding against each other. You can do the same thing with your foot. I'm not going to put my foot on screen, but with your foot, you have the ability to kind of turn your foot left and right within your ankle joint. And that ability to turn your foot to the left or to the right in your ankle is again due to those gliding surfaces of those planar joints found in between your carpals and in between your tarsals. All right. Questions on that? All right, excellent. Let's talk about a hinge joint. With a hinge joint, again, we identify these by the articulating surfaces. Basically, what we have is one convex surface. And of course, convex is something that curves outward, sitting in something concave, and concave is something that curves inward. So a hinge joint is made up of one convex and one concave surface coming together. Notice the example they gave us is that really super obvious U-shaped concave surface of the ulna and that really distinct convex surface of the trochlea. So we have the trochlear notch of the ulna, we have the trochlea of the humerus. They come together to help to form the joint of the elbow. And again, our elbow bends in one axis. I can't get my elbow to go over here to the side like that. Well, as I said, I could, but I'd be going to the doctor afterwards. So that is an example of a hinge joint. And again, hinge is probably the most common type. Hinge is what we see between the phalanges. Hinge is what we see in the knee. Hinge is what we see in the ankle, right? There are a lot of hinge joints. It's probably the most common joint found in the body. All right, questions on that? All right, excellent. Our next specific type is what is known as a condyloid or ellipsoidal. Ellipsoidal because, and I'm going to cheat here, it is an elliptical, which is basically an oval shape. And as we said, a condyle, remember, as we've been working through our bone features, a condyle is kind of a smooth oval surface. So notice basically what we do is we take a hinge joint that has a circle and we elongate it. And of course, then we also have to elongate the concave surface that it is going to sit in. And the advantage of this elongation is that it is going to allow not just one axis of motion, but two axes of motion. So as I mentioned here, between the proximal and the middle phalanx or phalanges, I have a hinge joint that allows one axis of motion. Here, between the proximal phalanx and the metacarpal, I have a condyloid joint, which is what allows me to do biaxial motions. Notice it doesn't draw it here, but here is the scaphoid and the lunate. And we know that the radius and the ulna sit down here as well. Notice they also form a condyloid joint, which is why I'm able to move my hand up and down this way. And I'm also able to do the princess wave, right? I can do, right, both movements in both directions because of that biaxial motion. So really it's a hinge that has been elongated. And like I said, notice it is the joint between the proximal phalanges and the metacarpals of 2, 3, 4, and 5. Why not the thumb? Why not digit 1? Yeah, digit 1 gives us a different, well, it actually is also biaxial, but it also gives us a more unique joint located in the thumb. Our thumbs are very, very special. Our thumbs are what allowed us to be the masters of the universe. All right. What makes us the masters of the universe? Well, of course, it must be brain size, right? We have the biggest brains. Do we have the biggest brains on the planet?
No.
No. Who has the biggest brains on the planet?
Dolphins, right?
Well, careful. Blue whales.
Elephant?
Blue whales have the largest brain on the planet, but they also have the largest body on the planet. So you're right. We're not anywhere close to being the biggest brain that way, but you're close because then we cheat. Okay, well, it's not absolute brain size. It's relative brain size. The size of your brain relative to the size of your body. And are we in first place there?
No.
No, as you guys mentioned, the dolphin is in first place. We're second, so we get the silver, so it's close. But if the dolphins have a bigger brain than us, why aren't they ruling the planet? I mean, if you think about it, the planet is 3/4 water. So they've got more space, they've got bigger brains. Why don't dolphins rule the planet?
They don't have thumbs.
They don't have thumbs. Exactly. All you need to rule the world is an opposable thumb, right? If nothing in the past 4 years, we learned that. If you can tweet with your thumb, you can be president of the United States. That's the only requirement, right? And what allows you to tweet? An opposable thumb. The reason your thumb is opposable is because it is a saddle joint. Notice here the joint between the trapezium and the first metacarpal is a special joint. And again, this is where my drawing skills leave us. So we started with a hinge joint. We elongated it into an ellipsoidal or condyloid joint. And basically what a saddle joint is an ellipsoid joint that's kind of been folded in on itself. So we have kind of a folded over condyloid, a condyle on this kind of weird shape, concave and convex structure. Like I said, my artistic skills lacking, but here we have the pretty picture that shows this. But this also allows biaxial motion, but what it also allows is it allows our thumb to be opposed. And by opposed, what I mean is that it can cross your hand. The fact that you can take your thumb and reach it across to the other finger, right? That ability to bring it across is what allows us to rule the universe. right? It's also what allows you to get home from bars. Back in ancient times, and by ancient times, I mean when I was in middle school, right? After a rough day of middle school, you'd go to the bar and you'd throw a couple back. And then the biggest concern was being able to drive home afterwards. And in ancient times, when you got pulled over for driving and they wanted to check to see if you were drunk driving, you had to do a dexterity test. You basically had to be able to go A, B, C, D, D, C, B, A. And so you'd sit at the bar and practice this while you got drunk so you could get home. A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A. And as you can see, I can still do it very, very well, even though I'm incredibly drunk right now. So that ability to oppose the thumb across our palm is what allows us to, again, rule the universe. And notice this is the only place we have that saddle joint. All right. So I think the take home message is screw the dolphins. All right. Questions on any of that? All right. Excellent. Let's talk about a different type of joint. This is a pivot joint. Notice it's a little bit of a cheat. The pivot joint is basically a ball and socket joint. You have a round bone shape, and then it is contained within a socket. So we have a socket that it sits in. So that is basically what a pivot joint is. Of course, it is going to allow us to rotate that bone in the center of it. But notice the example they've given us here. The example here is between the radius and the ulna. Now, clearly, we know that the radius, based on its name, has a nice big round head to it. But remember, the bone feature of the ulna that the radial head sits in is just this small little radial notch. That's not really a socket. However, as you can see from the illustration, you can see how they fix this. We have a tendon that wraps around that socket and wraps around that head and gives us that socket-like attachment. So here at the proximal part of my forearm, I have that ability to rotate my radius inside of my ulna. And that is that example of a pivot joint. Where else do we have this kind of peg and socket type of relationship? Do we have a kind of a nice round attachment where, nice big round attachment where there may be a bone that is connected to it. And then we would, of course, need some type of ligament to stabilize it in place to allow a rotation to take place.
Shoulder.
Oh, the axis
So
and
you are
atlas.
correct. We are able to rotate the head and the shoulder, and we'll talk about that in just a minute, but that's not the one I'm talking about. I am not
Back.
talking about the hip and the shoulder. Where else can we get that pivoting type of joint?
Your neck.
The neck.
Yeah, although be specific. What are the bones that are forming this type of pivot joint?
The atlas.
The dens and
There we
Axis
go.
of the cervical
Anterior.
vertebrae.
Atlas and the axis. There you go. The atlas and the axis. Remember, the axis has that dens that sticks up off of the body. And remember that our atlas basically is this round bone that's rounded. And then we have a ligament that's going to hold it in place. And that movement of the head side to side, that rotation of the shaking of the head is a perfect example of that pivot joint. So again, here at the proximal part of the radius and the ulna, but also I think an even better example is that relationship between the atlas and the axis is where we get that non-angular rotation. Now, again, remember, I'm meaning non-angular because it is along the longitudinal axis. Notice I could take the bone and I could rotate it that way. That would be an angular rotation of the bone. That's not what we're talking about. We're talking about along the longitudinal axis. All right. Excellent. That leaves us with our last specific type, the ball and socket joint. This, as you can see from the illustration, is we have a big round ball shape bone feature that sits in a nice concave pocket How many ball and socket joints do we have?
2.
Two. What are they?
The shoulder and the hip.
Yeah, shoulder and the hip. We've talked about the shoulder one already. The head of the humerus sits in the glenoid cavity, and that's what we see here in this picture. This ball and socket allows the most movement. Notice it allows multi-axial movement because, as we talked about, I can raise my arm up and down, left and right, everywhere in between, but it also allows for rotations as well. If I bend my elbow so that you can see this a little bit better, and I keep my elbow next to my body, and you can do this yourself as well. Notice as I bring my arm forward, you can see that my humerus is rotating. So we have this rotation of the humerus that is taking place as I'm doing that. So again, I can go up and down, forward and back, but I can also rotate this as well. Exactly. And that is the problem with this joint. While this joint allows for the most movement, especially here in the shoulder, it is the most dexterous of all of our joints, it is also the least stable. So it's the one that is most likely to dislocate. Notice our hip also is a ball and socket, but is it as equally likely to dislocate as your shoulder? No. And do you have as much range of motion with your leg as you do with your arm? No, even if you're Jean-Claude Van Damme, right, you can't move your leg around as much as you can move your arm. The reason for that is in our knee, there is an additional ligament, an internal ligament that actually attaches the head of the femur into the hip socket, holding it in place. That provides more structure, more integrity for more strength because it's weight bearing, but it does limit the range of motion. So yes, while we have two, your shoulder is definitely more dexterous than your hip. But as you mentioned, that also means it's less structurally sound. So it is the joint that is usually the most likely to dislocate. Excellent. All right, questions on that? All right, so as I mentioned in the previous class, I'm not going to point, obviously you have hundreds of joints in the body. Right. Now, as I've mentioned, you are not responsible for the names of the joint. I'm not going to hold you responsible for the names of the joint. But for every specific structural type, every specific type we've talked about, you should know at least one or two specific examples. So notice for all the joints we've talked about up to this point, I've given you at least one or two examples of them. And so make sure you know those examples. All right. Questions on that? All right, excellent. It is a teeny bit early, but this is a good stopping point. So let's go ahead and take our first break here. And then now that we've talked about the joints, we need to talk about the type of movements that they're going to allow. So again, it's a teeny bit early, but this is a good natural breaking point. So at 9:05, we will restart, and I will restart the recording again at that point. All right, any questions before we take our first break? No, it's typically stiffness in the neck has to do more with the muscles as opposed to the actual joint yourself. So typically, depending on how you sleep, the kink in it can decrease blood flow to a muscle, causing that muscle to become irritated or causing it to be stiff, which is why as you move it and you increase blood flow to it, or you take that nice heating pad and you put on it, it dilates the blood vessels, brings more blood to the area, and it typically loosens up as a result of it. So yeah, usually those are more soft tissue issues than as opposed to damage to the bones themselves or even to the ligaments. That's a great question. It really depends on the type of injury. I wouldn't say it really, I mean, It really depends on the type of injury. So like I said, you see plenty of examples of, and again, football is a great example because it's going on right now. Someone gets their leg bent back in the wrong way, and that clearly damages the joint. Whereas somebody else, the way they get tackled by the side, right on their shin or something like that, and they break the bone as a result of it. So I think, I don't think that one is necessarily more likely to be injured than the other. I think it is completely dependent on the type of assault that the individual is, taking on that would cause it, whether to be damaged or not. I mean, if you think about all the people who get tackled in the legs, I think, ligament injuries are more common than bone injuries, but I don't think it's necessarily that the joints are more likely to be injured. I think it's just the nature of the type of assault that, that the person is are taking. So I don't think it necessarily would be one or the other. It's a great question. I mean, the joints are more elaborate, and especially like in the legs where you've got the big thick bones, but I don't know, in other parts of your body, like your forearm and stuff like that, I would think maybe you're more likely to break the bones of your forearm than like damage your elbow. But again, it depends on the injury. Tennis people have major problems with their joints. So I think it really depends on the activities you're participating in. All right. Any other questions? Well, so be careful. We did talk about, so in the normal function of a tendon, as a tendon is pulling on the leg, tendons, because they've got the dense regular connective tissues, are incredibly strong. So if they're pulling on the bone, they're more likely to break the bone than to tear in the center. However, because all the collagen fibers are pointing the same direction, if you put a stress on them from an opposite direction, then they're more likely to tear. So that has to do more with the directionality of the tendons that we were talking about. So the tendon can be stronger than the bone in that relationship. But again, tendons are only strong in one direction of stress. All right, awesome. Any other questions? All right, I will see you guys. Actually, let's go ahead. I want to make sure we have 15 minutes. We'll restart at 9:10. See you guys at 9:10. Let's go ahead and get started. Now, we have now talked about the joints, and we need to talk about the types of movements they allow. This is going to be important for 3 reasons. 1, because it's going to be on the test. So obviously that's the most important reason. But 2, as we've talked about, this class is anatomy and physiology is all about vocabulary. You having the appropriate terms so that when you're talking on the phone to somebody across the country, they know exactly what you mean. So again, it's always about having a standard vocabulary. And the 3rd reason this is important is because this standard vocabulary is what we're going to be doing a lot of in the next section of this class. Once we've talked about the bones and we know how the bones and the joints allow for the levers for the movements of the muscles, when I talk about your bicep brachia and I tell you that your bicep brachia flexes the forearm, supinates the forearm, and flexes the shoulder, that has meaning to you. So we need to have this standard vocabulary so that not only that we can know it on this test so that we can talk about this meaningfully, but we're going to be using all of this standard vocabulary in the next section. So not just on this test, but on the next test as well. Some of these we've already talked about. Gliding, as we mentioned, is just that non-axial motion where we have that movement along the one plane without changing the angle. This is different from our angular motions where you change the angle. As we talked about here, I've got 90 degrees and now I have 45 degrees, right? So we're changing the angle between them. Rotation. Remember, when we talk about rotation, we talk about rotating something along the longitudinal axis of the bone. There is one trick we have to talk about in terms of rotations. A rotation on the midline is just that. The rotation on the midline is just a rotation. So as I mentioned, my head I am able to rotate my head, but I'm also able to rotate my vertebral column. Right? If I move to the end of the chair, it'll be a little bit easier. I can rotate my vertebral column. Again, it is on the midline. But remember, we also talked about how we have this ability with our shoulder joint and also with the leg joint, the hip joint, to be able to rotate the humerus. So I'll use my phone because it stands out a little bit better. Notice as I'm moving this arm this way, my arm is rotating in this fashion. Whereas if I do it over here, right, my arm is rotating in that fashion. When we talk about, or maybe I should use the pen because the pen might stand up more too. When I'm over here on the right side of my body, a rotation of my humerus that where the anterior surface goes towards the midline, then we call that a medial rotation. Whereas if the anterior surface goes away from the midline, then that is a lateral rotation. So notice over here on my right side, that would be a lateral rotation. Whereas over here on my left side, that same motion would be a medial rotation. So if we're not on the midline, when we talk about a rotation, it's all based on the direction the anterior surface moves. So if the anterior surface moves towards the midline, then it is a medial rotation. Whereas if the anterior surface moves away from the midline, then it is a lateral rotation. All right, so again, on the midline, rotation. If it's off the midline, then I can have a lateral rotation where it moves away, or a medial rotation where it moves towards the midline. All right, questions on that?
Can you give a few examples of bones that move laterally or joints that move laterally and medially?
Yes, I just gave you the two that do that actually, the shoulder and the hip.
So they count as both?
Well, those are two different joints, so yes.
Okay.
So notice, okay, here, if I stand up, and again, this is easiest to see if I bend my knee. Notice if I bend my knee, I have the ability to rotate my femur. Notice my femur moves away, so that would be a lateral rotation. When I do that, my foot goes the other way. Or I can medially rotate it where my foot goes out this way, but if you pay attention to the anterior part of the bone is moving towards the midline. So that's a medial rotation and a lateral rotation of the femur. So the femur and the humerus, the shoulder and the hip joint, remember shoulder and hip joints allow for rotations. Those ball and socket joints allow for rotations. They're the ones that you get the medial and lateral rotation. Okay?
Okay. Yeah.
Yep. Excellent. And then lastly, we have our special movements. These are ones that occur only at specific joints. We've already talked about one of these, the opposition of the thumb, and we will talk about some more as well. I think we understand what gliding is, and now we understand what rotation is. So what we need to do, we need to focus instead on our angular motions and our special motions. So those are the ones that we're going to identify. Those are the ones that we're going to give names to. So let's start easy. And not surprising, many of these work in pairs, like flexion and extension. What is a flexion? How would you
Up and
define?
down.
I'm sorry, say again.
Up and down.
Okay, but let's be more precise. You're close. You've got the right idea, but specifically, give me an example of a joint you can flex.
Our foot.
Okay, excellent. Or how about another one, the elbow, one that easier for me to demonstrate. right? Yes, using the bicep brachia, I can flex my elbow, right? Is that a flexion?
Yes.
Yes. What did I do there?
You decrease the angle between the two bones.
Bingo, exactly. A flexion is where we decrease the angle, right? What else can I flex besides my elbow?
Your knee.
Excellent. I can flex my knee, right? I'm doing that right now. Flex my knee. What else can I flex? I can flex my shoulder. I can flex my cervical vertebrae. I can flex my entire vertebral column. I can flex my hip. In fact, if I flexed everything at the same time, what would happen?
Become a ball.
Yeah, you curl up in the fetal position. Curling up in the fetal position would be an example of a flexion. A flexion is a protective motion. Notice one other thing about a flexion. Notice, and I'll stand up here so we can see this, whether I'm flexing my elbow or whether I'm flexing my shoulder or whether I'm flexing my head or whether I'm flexing my vertebral column or I'm flexing my hip, all of my flexions go anteriorly with one exception. What is the one exception of a flexion that doesn't come forward?
Your legs.
Well,
Well,
Your
back up
knee.
forward.
your knee.
Knee, exactly, absolutely. We make fun of the flamingos all the time because their knees are on backwards, but actually they're the only ones that have it right. Notice every single flexion of our body goes anteriorly with the exception of the knee. So a flexion is where we're decreasing the angle, and with that one exception, they go anterior. So what does that say about our extension?
You increase the angle and
Exactly,
they go posterior.
absolutely. With one exception, and what's the one exception?
Your knee.
Knee. So again, when I'm in anatomical, might as well just continue to stand for this. When I'm in anatomical position, I flex my elbow, I extend my elbow. I flex my shoulder, I extend my shoulder. I flex my head, I extend my head. Right? So what is hyper? Oh, and so let's think of this way. If I flex everything and I curl up into the fetal position, what happens if I extend everything?
You're standing?
Not just standing, but you're standing in anatomical position. When you're in anatomical position, everything is in extension. So then what is hyperextension?
When it goes
when you-
beyond. Oh, sorry.
Go ahead.
Like when the increased angle is even more increased, goes beyond the norm of extension.
Okay, what do you mean by norm? I like where you're going with this, but be more precise. What do you mean by norm?
Okay,
When-
so let's see. If your legs are, or if your knees are fully extended, and then they can go. I don't know. I have
Posteriorly.
hyperextension.
I think
Yes, I don't know
someone was
how to
trying to
explain
help you a little bit. So, okay, it doesn't necessarily mean double jointed, although I like where you're going with that. You guys have the right idea. Again, remember, as we talked about, if you're fully extended, you are in anatomical position. So a hyperextension is when you go beyond anatomical position. Yes, as you guys mentioned, if I were to do that with my knee, I would damage my knee and I would probably end up in the hospital again as a result of that. I've already had 3 knee surgeries. I would not like to have a 4th, right? But it doesn't have to be to the point that it's damaging. The neck is a perfect example. Flex, extend, hyperextend. Shoulder, flex, extend, hyperextend. Notice when I'm hyperextended, I'm not damaging the joint. I'm just going beyond anatomical position. And again, remember, it's all about increasing or decreasing the angles. If I take my shoulder and I go from here to here, what have I done?
Extension?
Well, but again, I went from here to here. You are correct. I decreased the angle. And if I decrease the angle, how would you describe that action?
Flexion.
No, yeah, I flexed it. Now you guys are right. My arm is still in a hyperextended position, but going from here to here is still a flex. The same way if I'm out here and I do that, that is an extension, right? I'm increasing the angle. Even though the arm is still flexed, I just extended the arm. So when we're talking about these motions, we're talking about increasing and decreasing the angle, and hyperextension is beyond it. Plenty of joints like the shoulder, like the neck, can easily be hyperextended. Many people, almost everybody, has some ability to hyperextend their fingers, although some can do it more than others. Almost everybody has an ability to a little bit hyperextend their elbow. Although, as you mentioned, some people are double jointed, in which their joints happen to be really loose and they can really hyperextend it. Depends on the joint. Some hyperextensions, if you hyperextend your knee, that's going to cause damage. Clearly, bringing my arm back like this doesn't damage it. Now, with my neck, can I hyperextend it to a point where I hurt myself? Sure. I can hyperextend my fingers, but if I push further, am I going to hurt it? Yeah. But isn't the same thing true this way? If I flex it and I smash them, wouldn't that hurt it too? So yeah, I
Yes.
mean, yeah, so it doesn't just have to be the hyperextension where they're injured, but you're right. Some can be hyperextended more than others. Does anybody have a really bendy elbow and want to show it off on camera? Because like I said, I know some people tend to be very double jointed, as they say, in that knee and in that elbow region, and can hyperextend it more than others. Shy class. All right. I know one of you out there at least can do it, but that's all right if you don't want to show it off. But there you go. That is flexion and extension and hyperextension. Questions on that? All right. Notice one other big thing that we mentioned about this. With the extension and the flexion, we moved anterior and posterior. Even the knee, which we have put on the wrong way, right? When it flexes, it goes posterior. When it extends, it goes anterior. It's still going anterior and posterior. So then the question becomes, if instead of coming forward or backward, I take my arm out like that, what do we call that action?
Lateral, like a lateral.
There you go. No, not a bad guess. There is such a thing as a lateral flexions, but lateral flexion only happens on the midline. So notice I can flex my head. I can extend my head, hyperextend my head. I can also laterally flex my head, or I can laterally flex my vertebral column. But, and I don't see who wrote this. Augustina. As Augustina point out, having the arm come out to the side is an abduction. Abduct, to take away. So then lowering it back to my side, what would that be?
Adduction.
A deduction, exactly. So I'm adding it, right? So again, abduct, you're taking away from the midline, you're abducting something, bringing it towards the midline, you are adducting. Notice there are other things that I can AB and adduct as well. My hand. Now, again, remember, we always assume anatomical position. So actually, let's look at it. As I'm down here, I can adduct my hand or abduct my hand. My hip can be abducted or adducted. And my hand has a midline. So my fingers can be abducted and adducted. So that ability to move away from or towards the midline is abduction and adduction. Again, it's not a lateral flexion. We can have a lateral flexion, but remember, this only occurs on the midline. and really only occurs with the vertebral column. Any movement of the appendage away or towards the midline is an abduction and an abduction. And now, like we talked about before, if we put a flexion, an extension, an abduction, and an adduction together, we can get that circular movement where basically we form a circle with the tip, but the point stays anchored. What did we call that motion again?
Circumduction.
Circumduction. And again, I can do the same thing with my shoulder as well. I can flex it, adduct, extend, and abduct. And if I do that together, I get that circumduction at my shoulder. And clearly I could do it with my hip as well. All right, questions on those angular motions? Notice all of those change the angle of the joint. All right, excellent. Then let's talk about some of the special movements. One special movement, again, these special movements typically only occur so rotation, remember, is the movement along the longitudinal axis. Whereas a circumduction, see, notice when I'm rotating, I'm not changing the angle, right? When I'm rotating, I'm not changing the angle between the pen and the phone. For a circumduction, I'm flexing, adducting, extending, and adducting. And here I am changing the angle as I'm moving it around. Notice also that when I rotate, the clip moves side to side. When I circumduct, the clip doesn't move. It stays in the same position. It is the bone that is changing angle. So this would be a circumduction. This would be a rotation. Great question. No. The head absolutely can rotate. However, notice a circumduction involves a flexion, an extension, an abduction, and an adduction. You are right, we could make a motion similar to a circumduction with the head because we could flex, we could laterally flex, we could extend or hyperextend, and we could laterally flex. So you could kind of make the same motion, but you don't actually call that a circumduction. Circumduction is basically just for the appendages, but you're right. Technically, we could make the same type of action with the head, but it's not called a circumduction. All right. Great question. Any others? All right. Let's talk about elevation and depression. What joint do we elevate and depress? Well, let's figure out, what does elevate mean?
To rise.
Yeah, bring up. So what does depression mean?
To lower.
Yeah. So what is an example of a joint that we elevate and depress? Well, again, that is a muscle that can cause those types of actions. Right. So absolutely, the shoulders. I don't know what I can elevate and depress. I don't know, right? Exactly. You can elevate your shoulders, you can depress your shoulders. Right? Is there anything else? Not the neck, but again, the shoulders. We're talking about bringing it up, bringing it down. Is there anything else you elevate and depress?
Your mandible.
Mandible.
There you go, your mandible. Excellent. Absolutely. Notice those two joints, your jaw and your shoulder, not only can they be elevated and depressed, but they can also be protracted and retracted. What does it mean to protract?
Extend or push
Well,
out?
yeah, stick out.
Mhm.
And what does it mean to retract?
Take back or put back.
Yeah, bring back. So again, our jaw, we can protract our jaw, make it stick out, or we can retract our jaw, bring it back. And the same thing with the shoulder as well. We can bring our shoulder forward and we can bring our shoulder back. Right now, with the protraction and retraction of the shoulder, it's a tiny bit more complicated. Right, there's my, of course, my rib cage. And here, of course, are my scapulas. So a protraction is where I bring the shoulder blade forward. However, notice as I bring it forward, those pesky ribs are in the way. So again, COVID is slowly starting to end, so you're allowed to see people again, and you see that friend you haven't seen in 2 years, so you go and give them a nice big hug, right? And as you hug him, or because you can't see friends, you're hugging yourself. As you bring your scapula forward, does it truly just come forward? No, what else does it do? Do that. If you're not sure, hug yourself. What else is it doing? It's coming out to the side, right? Notice it's sliding around towards the front. So when we talk about the protraction of the scapula, right? Notice it's also going away from the midline. So what could we also call this?
Abduction.
Exactly, an abduction, because we're bringing it away from the midline. Right? You're giving that friend you haven't seen in 2 years a nice big hug, and then you remember that they owe you $250 from before. So you bring your arm back to punch them in the face. And notice as you're retracting that scapula, what else is the scapula doing?
A deduction.
Yeah. Notice if you were to want to punch them with both hands at the same time, which again would be a silly thing to do, but like if you were rowing, notice as you bring this back, you can feel the muscles bunching up behind you in your back. And that's because as you are retracting the scapula, you're also bringing it towards the midline. So when we talk about a retraction of the scapula, we can also call it an adduction. So both of those are acceptable terms to use when talking about the shoulder. You can say you are retracting or adducting the scapula. You can say you're protracting or abducting the scapula. Both would be acceptable. All right. Questions on that? All right. Inversion and eversion. Where do we do this? What joint, what object of your body can you invert and evert? No? How about the foot? Again, I'll say that, let's pretend these were my feet. In my feet, I have the ability to turn my foot so that the soles of my feet are pointing inward. That would be an inversion. I also have the ability to turn my feet so that the soles of my feet are pointing outward. That is an eversion. So this is a turning of the foot so that the sole of the foot points medially.
Is it specifically just with feet?
Yep. Again, remember these special movements are just for one or a couple joints. An eversion is a turning of the foot. So the sole points laterally. And that's actually how I remember it. Let's think about it. If I think I've stepped on a piece of gum, and I want to see if I've stepped on a piece of gum, I invert my foot so that I can see if I've stepped on a piece of gum. If I want everyone else to see if I've stepped on a piece of gum, I would evert for every version of it. So evert for everyone, I-vert for me to see if I've stepped on a piece of gum, or to see if everybody else wants to see if I've seen eat a piece of gum. I stepped on a piece of gum. So
So why does
invert,
that like apply to your hands when you showed us the example of doing it? Why does that not count as an inversion or eversion?
because unlike my foot, I can take my hand and flip it over so that it's now palm up. Can I do the same thing with my foot?
No.
No. So notice this motion of my hand is a completely different motion. And in fact, what is this motion of the forearm called? Anybody know? Pronation and supination. Exactly. Oops. We'll cheat, jump ahead to that one. Pronation and supination. When I am in anatomical position, let's look at the bones. I'll draw them so that you can see what the bones would look like precisely in my arm. Of course, you can see that is the humerus, and that is clearly the radius, and that is clearly the ulna. There you go. You can clearly see now that the way my arm is oriented is the way these bones are oriented. And when I'm in anatomical position, my radius and my ulna are parallel. And this is, of course, the humerus. And when they're parallel, my palm, not how you spell palm, is anterior, right? In anatomical position. But I have the ability to turn my hand so that the palm faces posteriorly. When I do that, it turns out the humerus doesn't move at all. The ulna doesn't move at all. The only bone that moves is the radius. The radius actually crosses over the ulna. You can actually see this and feel this in your own forearm as you're doing this. As you're turning it over, you can see that radius rotating over the top. And so when my palm is facing posteriorly, again, that's still the humerus. This is still the ulna. This is now the radius, but they have crossed, and now my palm is posterior. So that rotation of the palm so that the palm faces posterior is a pronation. So when you P pronate, your hand is P posterior. When you rotate it into anatomical position, you supinate. I have lots of stupid mnemonics to help me to remember this. The stupidest mnemonic, though, isn't actually mine in your book. Your book says if you're going to hold a bowl of soup, you have to supinate. Notice if you pronate, you can't hold the bowl of soup. But if you're supinated, you can hold a bowl of soup. So there you go. So again, I'll take credit for lots of the stupid mnemonics that I use, but the soup one, that's totally your textbook. So this here, that ability to turn the hand backwards, that is a pronation, and this is supination. And it's because it's this very special movement of the wrist, right? You've got two parallel bones in your lower leg. Can you turn your foot so that your foot faces backward? No, right? Your foot, you do have the ability with your foot to kind of tilt it inward and tilt it outward. And there's some people who will commonly refer to that action as a pronation and a supination, but it is not a true pronation and supination. Especially runners. When you talk about runners, if their feet are pointing inward, they'll say they're pronated. If their feet are pointing outward, they'll say they're supinated. And they will use that term commonly with runners for those actions of the motion, but that isn't actually a supination or pronation, technically. Technically, it's just the forearm that pronates and supinates. All right. Notice there is a different action for the foot, and that is dorsiflexion and plantarflexion. Dorsiflexion and plantar flexion are having to do with, again, the fact that the foot is pointing anteriorly when we're in anatomical position. So what would again, if this was my foot, what would a dorsiflexion of the foot be?
Laying down. We're going.
It'll be
way?
upwards.
Upward, dorsal surface. So dorsal flexion would be an upward movement. So if you dorsiflexed your feet, what would you be doing?
Mm. Inflection?
Well, but I mean, if
Oh.
you're standing and you dorsiflexed both your feet, what would it look like? What would you be doing?
Going on your heel.
Yeah, you'd be on your heels. My daughter, when she was 2, my oldest, big, when she was 2 years old, she would walk around the house constantly in a state of dorsiflexion. She liked to walk around on the heels of her feet all the time. So she was in a constant state where she would walk around that way, right? She is 3 years older than Little. However, Little is now 3 inches taller than Big. So now when they stand around together, does she dorsiflex anymore? No, what is she constantly doing now?
Plantar flexion.
Plantar flexion, because what do you do when you plantar flex?
On your toes.
Up on your toes.
You get up on your tippy toes so that you can be a little bit taller. Exactly. Right. Again, the example I normally use for this is because we're sitting in class, and especially for an 8 o'clock in the morning class like this, it's not uncommon to sleep until 7:55. So you're running late for class. And so, of course, when you're running late for class, you dorsiflex on the gas to get here as quickly as possible. But what do you do when you see the cop car?
Plantar flexum.
Yeah, you don't step on the brake. If you step on the brake, you're toast. Instead, what you do is plantar flex, take your foot off the gas and hope for the best, right? So there you go. That flexion, that dorsiflexion and plantar flexion of the foot is that forward and upward motion of the foot. Get on your heels or get on your toes. All right. And then, of course, lastly, the one we've talked about already, that saddle joint of the thumb allows us to oppose our thumb to be able to touch those other digits, hold tools, tweet, and do all of those other fun things. All right. Questions on that? All right. So again, that is our vocabulary for our movements. That is the material that you're responsible for our synovial joints. We've talked about the basic anatomy, accessory structures, the specific types, and now we've talked about the types of motions and the actual names of the motions that they are responsible for. Yes, Aubrey, you have a question?
Yeah, so for opposition, it's both. That would be this action and back. This is both
Yeah,
opposition.
that ability to bring it across, this is the opposition. Yeah, you're
Okay.
right. That does make sense. Everything else, there's a and a B to it. But in this case, that's just that bringing it across, that opposition. It's just a one name for that one action. It's a great point. I've never thought of that before, but that's an awesome point. You're right. There should be another name for the bringing away from across the thumb, but nope. All righty. Awesome question. That's cool. I never thought of that. Any others? All right, excellent. Now that we've talked about everything you ever wanted to know and more about how joints function normally, we need to talk about our homeostatic imbalances to joints. And of course, one of the biggest homeostatic imbalances that happens to our joints is the act of aging. What effect does aging have on our joints? Give me some examples of what aging does to our joints.
Makes them more porous.
What do you mean by porous?
I guess less calcium is being.
So you're right, absolutely. One of the things that happens is our bones themselves get weaker. And if the bones get weaker, that can cause problems with the joints. Absolutely. Excellent. Less elasticity, less range of motion. Absolutely. We get less range of motion. Less elasticity to what? That decreased range in motion occurs because we have less elasticity in the ligaments and tendons. Our ligaments and tendons shorten, they lose their elasticity. So our flexibility, our range of motion decreases as we age. Right? It's one of the reasons why continuing to stretch, doing things like yoga and Tai Chi, even at an older age, are things that can help to maintain the elasticity, can maintain the range of motion for our joints. What else?
You have
Natural
less-
wear and tear.
Yeah, absolutely. We're going to get increased wear and tear on the cartilage. Obviously, while the cartilage helps to cushion and protect, it is going to thin with age. That's going to be a problem. But remember, the other thing that is maintaining that cartilage is the synovial fluid. And we also get a decrease in synovial fluid production when we age. All right? Big loves to run. So she could be sitting on the couch, right, finishing off her, her binging of Squid Games. And as soon as she's done, she may get excited to go up and go run 5 miles. So she bounces right off the couch and she's outside running without any problems at all. Can I bounce off the couch and go running 5 miles without any problems at all?
No.
No.
No, right? Because my joints, the ligaments are tightened. My synovial fluid is less of it's being produced. So like we talked about, I need to stretch. I need to warm up more. And part of that stretching and warming up, as we talked about earlier, is increasing the temperature. When you increase the temperature, when you increase the activity of the joint, you increase the amount of synovial fluid that's in there. So by making more synovial fluid, that will provide more protection for my joints, help the joints to move more smoothly. So without that, again, you get more damage to the cartilage. As you get more damage to the cartilage, the joint will move less smoothly as a result of that. And you can also get bone damage, and we already said the bone could be weaker as well. So all of these are things that can occur as we age. And is it going to affect all of us equally?
No.
No. There is a huge, strong genetic component to how sturdy our joints are. Right. Again, this is something you see in sports all the time. You see baseball players, again, playoffs are going on right now. So you see some of these catchers in baseball have been sitting in that squatting position for 12 years in the major leagues. And that doesn't include the 3 years they spent in the minors, and the 2 years they spent in college, and the 4 years they spent in high school, and the 3 years they spent in Little League, and so on and so forth. They've been squatting for half of their lives, and yet they're still able to do it. Whereas other people, they spend 1 season trying to be a catcher, and they have problems with their knees for the rest of their lives. Right? So there's a huge genetic component. We could all do the same activity the same number of times, but is it going to affect all of our joints equally?
No.
No, absolutely not. I appreciate that does, Augustina, that does sound counterintuitive. But again, remember, there's a big difference between me sitting here and stretching, my arms and my shoulders and my joints, and me running, right? When I'm running, I'm doing a lot more vigorous physical activity. So the point of the stretching, the point of the moving ahead of time is to do smaller, less impactful activities that are going to warm the joints up and increase the synovial fluid production before you then go the much more difficult. And again, it isn't just running. When you're weight training, when you're lifting weights, when you sit down for your very first rep, do you do the maximal weight that you're going to do for that activity?
No.
No, you start with much less weight to warm up, less impactful, warm up the joints, increase the synovial fluid so that you're better able to do the more vigorous activity with more protection to those joints. So yeah, so you ease your way into it, and that easing of the way into it is what helps to I'm hesitant to say the word bad impact, but here are the two things that I will talk about with weightlifting. Again, huge genetic influence. If we all lifted the same number of weights the same number of times, would we all have the same effect on our joints as a result of that?
No.
Where weightlifting is more, I'm really hesitant to say the word dangerous, but where you can have more problems with weightlifting is you're seeing now more and more adolescents and even young teens doing very heavy and impactful weightlifting. Remember, one of the things that we've talked about is that stress on the bone increases that production of that electrical current. As we're stressing the matrix of the bones, that produces an electrical current and that stimulates the osteoblasts. So one of the things that you're seeing with some of these adolescents who are starting heavy weightlifting at 8, 9, 10 years of age is that kind of major heavy weightlifting can cause premature closing of their epiphyseal plates. Because of that increase in electrical activity, of that increase in stress, it can actually stimulate the bones to close the epiphyseal plates prematurely. So, so again, from a often you're not using all of your weights, all of your bones evenly with that, so you can get some asymmetrical premature closing. So, for instance, the arms may close before the legs do, or things along those lines. So that can sometimes lead to complications at an earlier age. As a adult with closed epiphyseal plates, it's less of a concern for that way. And as we know, weight-bearing exercises are good for the bones. But yeah, if anytime you're stressing a joint, whether it's from running, whether it's from lifting weights, you know, when you use it, there is the potential to impact it. And again, genetics really has a huge influence of whether or not it's going to, you know, how quickly it will wear down. All right. So yeah, doing things like properly warming up in time definitely can help to mitigate some of those potentially bad impacts. Absolutely. Now, aging is something that happens with everyone. Something that doesn't necessarily happen with everyone is arthritis. Now, we throw out the term arthritis as if it's a singular thing. But what does arthritis actually mean?
Homeostatic imbalances.
True, but specifically what? Yeah, there you go. Itis means inflammation. Arth refers to the joints, so it's just inflammation of the joints. Arthritis, though, isn't just one thing. And one of the easiest ways to see that is to look at the two most common types of arthritis. The two most common types of arthritis are osteoarthritis and rheumatoid arthritis. So let's talk about these two. Let's do this on the whiteboard. Osteoarthritis is kind of what we've already been talking about. This is pretty much the wear and tear of the joints from use. All right. So with osteoarthritis, which joints are typically impacted?
The hip.
The wrist.
The knees.
Perfect. That's excellent. Typically, this impacts our big weight-bearing joints, or, as you pointed out, joints that are used a lot. So like I said, those knees, those hips are perfect examples. But if you're a secretary who's typing 140 words a minute, right? Then that can affect the wrist. If you're a tennis player who's constantly waving a racket around, that can affect your elbow. So typically it is the big joints that are the big weight bearing or joints that are used a lot are the ones that are impacted most by this. And using that tennis player as an example, are both elbows going to be equally impacted for them? No. It typically for this is asymmetrical. Now, again, if you are a catcher in baseball or softball, where you're constantly using both knees to squat down, is it going to affect both knees? Likely, but are they both going to be 100% exactly impacted the same way?
No.
No.
No, not necessarily. So typically this tends to be asymmetrical.
Is arthritis genetic?
Again, you are correct. There is a genetic component to this. As we mentioned, some people's joints tend to wear down more than others. So, you know, if your dad had an or grandpa had an osteoarthritic hip, there is an increased likelihood that you could. Again, there's a component to it, because again, it all goes down to how, I don't know the right word. We'll say sturdy for lack of a better word. We'll put it in quotes. The joints are resilient, might be a better term. But so there can be a genetic component to it, but it's mostly use-based, right?
So it's
So
not like once you get it in one area, you're going to be bound to get it in others.
No, and that's also a perfectly good example. This one, does it spread to other systems?
No.
No, exactly. Probably my favorite example of this is my grandfather. My grandfather had osteoarthritis in both of his knees. And so he had both of his knees replaced. And after he had both of his knees replaced, did he have any problems anymore?
No.
No. In fact, he would, still using his walker every day after the surgery, using his walker, would walk out to the tennis court, put his walker aside, grab his racket, beat the crap out of me in tennis, and then grab his walker and walk away from the tennis court afterwards, right? This doesn't spread to other areas or to other systems. So if you have a problem with your hip and you replace the hip, you're fine, right? And it doesn't affect the eyes or the skin or any other systems like that. It's a silly question, honestly, right? And again, this is an arthritis associated with use. So if you've got that osteoarthritic knee, does it feel better first thing in the morning when you wake up and you've been laying in bed for 8 hours? Or
No.
does it feel better after 8 hours of walking around and waiting on tables for 8 straight hours?
Mostly not that. But sometimes waking up in the morning can be a little stiff.
True, it can be stiff in the morning. Yes, it can be stiff from lack of use, but it is definitely more painful at the end of the day.
Absolutely.
Right? So again, yes, it can be a little stiff in the morning, but the more you use it, the more painful it is going to be. Now, by comparison, let's talk about the second most common type of arthritis, and that is rheumatoid arthritis.
I have a question real quick about the
Yeah.
osteoarthritis.
Yeah.
So because of the wear and tear, so basically it's because of the thinning of the cartilage and the lack of synovial fluid between the bones is why you're getting that inflammation?
Typically, you've got the right idea. This one is typically due to damage to the cartilage. That damage to the cartilage could be the thinning of it due to age. It could be because you're producing less synovial fluid, and so it's more likely to be damaged. So this is damage to the cartilage, and as the cartilage thins and the damage thins, this also leads to damage to the bone as well. So the bone itself can become damaged from that impacting of it. All right.
Thank you.
Yeah, no, great. That's a great point. I'm glad we made that because that will also, it's another way it's different from rheumatoid arthritis. What do you know about rheumatoid arthritis? Anything?
That if one shoulder gets it, another shoulder will get it.
You are correct. This one, unlike osteoarthritis, this one is more typically symmetrical. Now, is it always going to be perfectly symmetrical?
No, just
No,
most.
but- yeah, but it is typically more symmetrical. What else do we know about rheumatoid arthritis? Anybody know the cause of rheumatoid arthritis? It's okay if you don't. Just a lot of people, there we go. That's what I was looking for. And not just an immune response, but what we call an autoimmune response. An autoimmune response is actually where our own body defenses, the body's cells that are supposed to defend us from outside foreign invaders, instead, those body defense cells actually incorrectly attack our synovial membranes. They destroy the synovial membranes. When they destroy the synovial membranes, the amount of synovial fluid that is produced decreases. So notice this one is caused by damage to the synovial membrane. And as a result of that, not only do we get damage to the synovial membrane, but it produces scar tissue in the joint. And that can cause the joint to swell and actually can cause the joint to displace. Excellent. Now, if my immune cells destroy a single square centimeter of synovial membrane in a big, huge joint like my knee or my hip, is losing 1 square centimeter of synovial membrane going to have a huge impact on the function of my knee? Probably not. But what if I lost a square centimeter of synovial membrane here between my middle and my distal phalanges?
Yeah.
Yes.
Yeah. So notice with rheumatoid arthritis, typically this impacts smaller joints first. Does that mean you can't get rheumatoid arthritis in your hip or your knee? No, you certainly can, but it's going to be the smaller joints that are going to be impacted first because it's the smaller joints that have less synovial membrane. So the joints that have less synovial membranes in them are going to be the ones that are going to be affected more first.
So is this one not caused by age? Like
It is more common. So that's a great. We don't know the cause. There are some things we do know. Once again, there is a genetic component. If a grandparent had rheumatoid arthritis, your mom's or dad's more likely to have rheumatoid arthritis. You're more likely to. But it isn't like rolling your tongue or curly hair. It's not something that is directly genetically inherited. We don't actually know the cause of rheumatoid arthritis. It's believed to be a combination of things. One is you have a genetic predisposition to getting it. And then when exposed to some type of environmental factor, it could be stress, it could be a particular virus or something like that, then it causes it to occur. But we don't know the cause. We do not know the cause, but we do know that there is a genetic component to it. No. So osteoarthritis, as you produce less synovial fluid as you age. So the fact that you produce less synovial fluid means that there's more likely to be damage to the cartilage, more likely to be damage to the bone. But the inflammation and the damage to the bone in our osteoarthritis is more due from the damage, the impact on the cartilage and the impact on the bone. Here, your immune cells are destroying the synovial membrane. yes, if the synovial membrane is destroyed, you can't make as much synovial fluid. So yes, both of these see a decrease in synovial fluid production, but one is just simply because of age. In this case, your immune system is attacking that synovial membrane and destroying that synovial membrane. So you're not making more synovial fluid, you have less functional synovial fluid. It's destroying the synovial membrane.
So because it attacks in different synovial membrane places, does that mean it spreads? Not spreads, but it is affected in more areas where
Right.
there's.
Exactly. If I have rheumatoid arthritis here in my joint between my phalanges, if I get that joint replaced, do all my problems go away?
No.
No, because I still have those immune cells that can attack other membranes. So absolutely, this one can spread to other joints, and this one can actually spread to other organ systems. Rheumatoid arthritis can affect the skin, it can affect the lungs, it can affect the heart. It can affect other organ systems. The inflammation you see in rheumatoid arthritis is because of a buildup of scar tissue. That scar tissue, it's not that it's producing more synovial fluid, it's that you're producing more scar tissue. And that scar tissue and that inflammation can actually lead to displacement of it. I mean, here.
So then it hurts all the time, not just like when you use it more.
Well, we'll get to that in a second. Not the best picture, but an easy, quick one I could found. Notice early on, it starts with just some redness and inflammation. But as that synovial membrane continues to be destroyed and as scar tissue starts to build up, the joints can become quite enlarged and inflamed, and the joints can actually become displaced. The bones can actually become displaced from each other because the buildup, not of synovial fluid, but because of the buildup of scar tissue. So it is scar tissue that is forming inside of these joints that is causing this displacement and this scarring of the joint. Now let's get back to what you were talking about. So in this case, again, our synovial membranes are being destroyed. So clearly we're not producing a lot of synovial fluid. So when grandma with her rheumatoid arthritis wakes up first thing in the morning, and not only does is half of the synovial membranes in her hand gone, or destroyed or scarred up, but also she hasn't been moving it for 8 hours. How does her hand feel first thing in the morning?
Painful.
Yeah, but then she goes into the kitchen and starts turning things on. And one of the big things she turns on is the coffee pot. And she grinds the beans and she puts it in there and she makes herself a cup of coffee. And as she takes that cup of coffee and wraps her hands around it, and the heat from that cup of coffee enter into her joints, and as they warm the joints and they start making a little bit more synovial fluid, how does her hand start to feel as she starts to use it and move it?
Better.
Yeah. So notice this one typically is worse in the morning, but gets better with use. Now, does that mean by the end of the day, her hand's going to feel perfectly normal?
No.
No, as she continues to move it, is it going to fatigue? Is it going to tire? Is it going to become sore? Yes. But in this case, because of the lack of synovial membrane, a little bit of use, a little bit of warmth helps to make it actually feel better. So typically,
Is there any like medication or anything you could take?
Yeah, there are. So again, just as we don't know the cause, there is no cure for rheumatoid arthritis. However, are there medicines that can be taken? anti-inflammatories and things along those lines that can be taken that can lessen the symptoms, lessen the pain? Sure, absolutely. Right. And like I said, something as simple as wrapping your hands around a warm cup of coffee, increasing the movement of those. Those are things that can help it to feel better. But there is no cure for rheumatoid arthritis. Right. And unlike osteoarthritis, you can't just replace the joint and everything's better. So notice arthritis is an inflammation of the joints, but here we see two dramatically different types. All right. Questions on that? All right, excellent. With that, that is everything we need to do from a lecture standpoint for today. So we have a couple hours left, so that's going to give us an opportunity to break into our groups and to do our final presentations. Let's go ahead. We'll call it a 17-minute break. Let's come back at 10:30, and at 10:30 we will start our groups. So I will go ahead and break you guys into the groups now. So go grab a break and something to eat, drink, caffeine, biological break, whatever it is that you need. And at 10:30, we'll break into our groups and start working on our group materials. That should give us a couple hours, which should be plenty of time to get through everything we need there. All right, any questions? All right, I will break us into our groups and then I will see you guys in 15 minutes.